Hello, 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 ladies and gentlemen. Today we are talking about infectious disease. So welcome back. It's been a while since I've talked with you. So, the learning objectives for this section discuss the nurse's role in reporting of communicable diseases as reported by law. Usually the facility will take care of this if we think that it may be an epidemic, and we know that an epidemic is much smaller than a pandemic that we are dealing with right now. So unless, of course, this is out in the community and it's the public health nurse that is doing this, she would have to report the outbreak of this communicable disease. Identify resources for assisting clients in the community to prevent and manage chronic or communicable diseases. Again, that would be the public health nurse, the community nurse. Describe the concept of emerging infectious diseases and factors that lead to the development of these diseases. Discuss the delivery of safe and effective care of the patient with a communicable disease, and discussing how home health care measures can reduce the risk of infection. So, defense against injury. Some of our defense mechanisms are the skin and the mucous membranes, as these are the first line of defense. The mononuclear phagocyte system, the inflammatory response, and then the immune response. So the inflammatory response. Inflammation is often and incorrectly used as a synonym for infection. These are two different things. An area, a joint can be inflamed, can be angry, pissed off, and not necessarily infected. However, when you have an infection, usually that area is inflamed. Inflammation is always present with infection. However, infection is not always present with inflammation. Infection involves invasion of tissue or cells by microorganisms such as a bacteria, a fungi, and a virus. So the cellular response. We begin with the neutrophils. First, the leukocytes are the first to arrive, and we know that leukocytes are those little baby white cells that grow up to be mature W white cells, which are the neutrophils. So the leukocytes are the first to arrive, and if there is an injury, they usually arrive within 6 to 12 hours. They have a very short lifespan, 24 to 48 hours, so these dead neutrophils will soon accumulate. And then the mixture of the dead neutrophils, any digested bacteria, and then other cell debris that is going to accumulate in this wound at this injury site is seen as a creamy substance, and we call that pus. It's a very technical term, very medical. So, in order to keep up with the demand for neutrophils, the bone marrow will release more neutrophils into the circulation, because this is how we combat infection, is how we combat the inflammation. It's how we are rushing to the site of the injury to help the injury to heal. And then if we are looking at labs, if we are in the clinical setting and if we are looking at labs, what we will see is the WBC count, the white blood cell count, especially the neutrophil count, will elevate. So the demand for neutrophils may increase to the extent that the bone marrow will release immature forms of neutrophils, and these are called bands, into circulation, because again the body is working very, very hard to get to this injury and to help the injury to heal. The finding of increased numbers of band neutrophils in circulation is called a shift to the left. A shift to the left. And we have discussed this before, where if you are looking at If you are looking at lab studies or if you're looking at doctor's documentation, you will see that sometimes he will say a shift to the left. And this shift to the left is commonly found in patients with an acute bacterial infection. So now the monocytes. The monocytes are the second type of phagocytic cell that will migrate from the circulating blood to this injury. They will arrive at the site within 3 to 7 days after the onset of the inflammation. These are important in cleaning up the area before any healing can occur. They have a very long lifespan. They will multiply and stay in the damaged area for weeks because they are working on the healing process. So these monocytes are very important in orchestrating the healing process. They work very, very hard for the body. Now the lymphocytes, they will arrive later, and they are the primary role in facilitating humoral to cell-mediated immunity. So now, when we are in the clinical setting and you are looking at your lab studies, one of the things that you will see is the CBC. And along with the CBC, doctor will also do what we call a CBC with a differential. And there is a lot of valuable information, not only in the CBC, but also in the differential. And looking at the differential, we can kind of sort of gauge, that was very, very medical, kind of, sort of. We can anticipate where the infection may go, and doctor can interpret this in creating the treatment plan. So the CBC is going to test for RBCs, hemoglobin and hematocrit, the reticulocytes, the mean corpuscular volume, and the platelets will also be checked when we are looking at the CBC. So the red blood cells, the RBC, the red blood cell count, will be low with iron deficiency, blood loss, hemolysis, and then bone marrow suppression. Increases can reflect the body's attempt to compensate for hypoxia. Autologous transfusions are often considered before surgery to reduce the risk of blood-borne infections and then transfusion reactions. There is a decrease in a transfusion reaction if someone is going to have a surgery, if they are able to, if they can go and donate their own blood before the surgery. Hemoglobin, millions of hemoglobin molecules in each red blood cell. And it is this way that oxygen is carried from the lungs to the body tissues. It is carried on the hemoglobin. Then the hematocrit. The hematocrit will measure the volume of cells as a percentage of the total volume of cells and plasma in whole blood. So after hemorrhage or excessive intravenous fluid infusion, the hematocrit will be low. And so the hematocrit is low because in putting these IV fluids into the circulatory system, then everything is dilute, right? So the red blood cells are going to be spread further out. So since the cells are further out and they're diluted, then the hematocrit is low. If the patient is dehydrated, then the hematocrit will be increased because there is less volume, less fluid in the circulatory system, and then everything is kind of sort of hunkering down together. So when you're looking at the CBC and you see this discrepancy in the H&H, or doctor is looking and seeing the discrepancy in the H&H, one of the things that he's going to want to go back and look at is, was this patient on IV fluids? Because that could be the contributing factor to the discrepancy in the H&H, and not exactly blood loss or bleeding. The reticulocytes are new cells that are released by the bone marrow. They are little baby red blood cells, and they are used to assess bone marrow function and can indicate the rate and then the production of RBCs, because that's where all of this happens, right in the bone marrow. Platelets. Platelets, thrombocytes, are small elements formed in the red bone marrow, and they will help to control bleeding. So, many conditions can elevate a platelet number. A few of them may include thrombocytopenia, chronic leukemia, depending on the stage and then the therapy, iron deficiency anemia, malignancy, and then chronic infections or inflammations. All will elevate the platelet number. Eosinophils. These are found in such areas as skin and the airway in addition to the bloodstream. They will increase in number during allergic and then inflammatory reactions and then parasitic infections. So, infectious diseases. Ladies and gentlemen, listen up, and then listen up one more time for me. Infectious diseases are caused by pathogens. Pathogens are microorganisms that are capable of forming diseases, and there are many routes of transmission. Many routes of transmission. Please, ladies and gentlemen, listen up and please know these routes of transmission. So contact. Contact is very, very simple, right? It occurs when a person or an object comes in contact with a pathogen. Your hand, your clothing, and then you touch your clothing. Maybe someone who was not well touched a doorknob and now the pathogen is living on the doorknob, and you come along and touch the doorknob with your hand, and this is the most common mode. Contact transmission is the most common mode. Airborne, again, very, very simple. It is when pathogens are carried through the air and then we inhale them. Very, very easy to remember. Vehicle. Vehicle is an indirect mode of transmission that will occur when a disease-carrying agent touches a person's body or is ingested. So in this way, we can think of it as someone is not well, or they're coughing, sneezing as they are preparing food or drink, and then we eat the food or drink, and then that would be the vehicle. And then vector. Vector is also an indirect mode. An organism transmits a pathogen, such as a bite, an insect, or a tick that will infect a person. Ladies and gentlemen, listen up, and then listen up one more time for me. When an infectious disease is spread by direct contact, the microorganisms are transferred directly from person to person. When an infectious disease is spread by direct contact, the microorganisms are transferred directly from person to person. Contact, direct contact. So in indirect contact transmission, microorganisms are spread from a source to a susceptible host by passive transfer from an inanimate object to an object or substance capable of carrying an infectious organism. So again, something inanimate, the doorknob, a door handle, your clothing, and then I am going to carry it and transmit it to somewhere, my face, where I will become infected with it. So, in healthcare settings, patients acquire infectious diseases through indirect contact via. Ladies and gentlemen, listen up, and then listen up one more time. In healthcare settings, patients will acquire infectious diseases through indirect contact via unclean hands of healthcare workers. This is because we may be just using the hand sanitizer and we are not using hand washing technique or we are washing our hands, but we are not washing them properly. We're not washing them long enough. So performing hand hygiene before and after care is a priority. Ladies and gentlemen, please listen up. Performing hand hygiene before and after care is a priority. And we know this, right, from this pandemic, from dealing with these COVID patients, and then also from dealing with just trying to stay well in our own lives, how much we have had to stress hand washing. It is also spread through indirect contact via contaminated equipment or a contaminated environment where we do not clean up properly. Nosocomial infections are infections that are acquired in the hospital that were not present with the client on admission. Multi-drug resistant MDR organisms are common causes of these nosocomial infections. Some examples of these MDR organisms, these multi-drug resistant organisms that will cause nosocomial infections, are Methicillin-Resistant Staphylococcus aureus, which is commonly known as MRSA. We have all heard this, right? It's a very common term. Vancomycin-Resistant Enterococci, VRE. Clostridium difficile, otherwise known as C-Diff. And then Acinetobacter baumannii. So, Staphylococcus aureus, S. aureus, is a common asymptomatic pathogen that is considered normal bacterial flora of humans. This is the natural staph, the staph that is very common, and it is on the top of our skin. However, when there is an injury to that skin barrier, which again is the first line of defense, and there is a little bit of inflammation and a little bit of infection, doctor will say, nurses may also assess and say, it looks like you have a staph infection. That is because there is bacteria mixing in with that normal flora. And two people in 100 will carry this staph aureus. So, ladies and gentlemen, listen up, and then listen up one more time for me. Approximately 33% of healthy individuals are colonized. That means the host will carry the bacteria without being infected themselves. And they will carry these pathogens. These pathogens will live in the nose. Ladies and gentlemen, pay attention. It is the nose which is a very common site for this pathogen, for MRSA. In the throat, in the axilla, the web of the toes, and in the perineum. But the nose is the most common site. So the most common site of colonization for MRSA will be the interior nares. And we know this if you have been in the hospital setting, if you have, or maybe you've done this yourself where you have had to be swabbed for MRSA, or if you're looking in your patient's chart and there was a MRSA culture that was obtained, and when you're looking at the result, you will see that it was obtained right nare, left nare. Although 33% are colonized, fewer than 2% are infected with it. The first documented outbreak occurred way back in 1968 in the United States. In 2007, many years ago now, the Association of Professionals in Infection Control and Epidemiology reported an estimated 1.2 million were hospitalized with MRSA each year in the United States. Today, approximately 70% of Staph aureus isolates from clinical cultures are MRSA. Again, it is that staph infection. Result of decades of unnecessary antibiotic use and is currently resistant to all beta-lactam antibiotics, including penicillins, cephalosporins, and then the carbapenems. These antibiotics do not work for MRSA. Ladies and gentlemen, listen up, and then listen up one more time for me. The National Health Care Safety Network reported the incidence of MRSA central line associated bloodstream infections decreased in recent years in the intensive ICUs. So in the intensive care unit where there are a lot of lines, right? A lot of tubes, a lot of lines going into the body. We are now seeing a decrease in the most recent years. Decrease, in MRSA infection rates is attributed to general infection control efforts, such as the use of alcohol-based hand rubs, which I don't really care for, but people use them. Then improved hand hygiene, so we are washing our hands more and we are washing them more effectively. Targeted efforts at eliminating these bloodstream infections, and then the enhanced antimicrobial stewardship programs. This means that when we are changing those central line dressings, we are being more careful. We are gowning, we are gloving, we are masking the patient, and we are using those antibiotic discs that are now in the central line dressing change kit. The first case of community-acquired CAMRSA, community-acquired MRSA, was reported in the United States way back in 1980. It has become the most frequent cause of skin and then soft tissue infections presenting to emergency departments in the United States. Hospital-acquired MRSA, HAMRSA, leads to more invasive diseases such as bloodstream infections, those central line infections, those IV infections, surgical site infections, and then pneumonia. Hospital-acquired MRSA and community-acquired MRSA have different molecular characteristics. Community-acquired MRSA strains are resistant to beta-lactam and macrolide antimicrobials, but they remain susceptible to many non-beta-lactam antimicrobials. Hospital-acquired MRSA strains are resistant to many other classes of antibiotics in addition to the beta-lactam and the macrolide antibiotics. So recent studies will suggest that hospital-acquired MRSA and community-acquired MRSA should be treated on the basis of the type of infection and then the antibiotic susceptibility rather than the strain of bacteria. So all of this means is that we are going to look at the infection. We are going to culture it. If there is a wound, if it is a systemic infection, we're going to do a blood culture, and then we are going to treat each of these infections individually. We're not going to class them as hospital-acquired, and then this is the antibiotic that we're going to use. That's not what we're saying. What we're saying is that studies now suggest that we have to treat each individual infection individually. This is now considered patient-centered care. Ladies and gentlemen, listen up, and then listen up one more time for me. Risk factors for hospital-acquired MRSA is a current or recent intensive care unit stay. A current or recent intensive care unit stay. Other risk factors are invasive procedures, medical devices such as urinary catheters or IV lines that create a portal of entry because, again, it is a break in that skin barrier, and that skin is the first line of defense. Recent or long-term broad-spectrum antibiotic use allowing the bacteria to become resistant to a specific antibiotic, and people with a weakened or immature immune system, such as young children, the elderly, people with HIV or AIDS, as well as diabetics, people with congestive heart failure, and then those that are immunosuppressed. Risk factors for community acquired MRSA will include children that are younger than 2, athletes, IV drug users, men who are having sex with other men, military personnel, patients that are living in correctional facilities or in shelters. Risk factors are associated with close skin-to-skin contact, crowded living conditions, and then those places where people are practicing poor hygiene. So, pathophysiology, I always like to include a little bit of background. MRSA is not naturally found in the environment, but it is found on humans. It can live on surfaces and humans for days to weeks. When a person is colonized with MRSA, the endogenous pathogen, and this is the pathogen that is residing on the body, can easily be transferred to the skin of other body areas, increasing the risk of infection. For example, a patient is colonized with MRSA in the nose. The patient is going to wipe their nose with their hand, and then they may touch their open wound. They're not going to use a tissue. They're going to touch around their face. They're going to touch where their nose is. They're not going to wash their hands. They're not going to use a sanitizer. They're not going to think anything of it, and then they may be touching down. They may be touching their dressing. They may be touching down around an open wound. So the bacteria can then be transferred from the wound and cause an infection. Infections are also caused by exogenous, which is outside the body sources. Mode of transmission is contaminated surfaces. It can be spread if an infected person touches his source of infection and then touches another object or a surface. So somebody is going to touch their wound, and then they may touch their bedside rail, they may touch their overbed table, they may touch a cup at their bedside or their water pitcher, and then we come in and we're moving things around in the room. We may not be wearing gloves, and then therefore it is transmitted. So in order to prevent this, the CDC will recommend covering cuts and open wounds with bandages and maintaining good hygiene, including bathing and showering regularly. I can't believe that I have to say that, but I do. And the more common mode of transmission, again, is direct contact. It is easily spread, especially in the hospital and other healthcare settings, from patient to patient or from body part to body part, on the unwashed hands of healthcare personnel or through improperly cleaned equipment. So, I need an IV pole. I need an IV pole in room 2. I know that there is an IV pole in room 1 that is no longer being used. I don't have time. I don't have time to call environmental services to say, come and please wipe this down and clean it for me. And so I am just going to get the IV pole out of 1. I'm going to wipe it down. Maybe I'm not wiping it down incorrectly. Maybe I am not giving it enough time to dry. And then I am going to take it into room 2 because I need it, and I need it now. Proper hand hygiene is essential when caring for patients with MRSA. Clinical manifestations. Staph aureus minor skin infections include pimples, abscesses that will develop because people can't leave their own pimples alone, and they open them, they pick them, they break them open, and then there we go, we have an infection. Styes, and then impetigo. Ladies and gentlemen, listen up, and then listen up one more time for me. MRSA is a more serious infection than Staph aureus. It will include pneumonia. So with pneumonia, what do? We have to move those secretions in the lungs. We don't want them to sit there, so we are going to encourage ambulation. We are going to administer oxygen. We can implement chest physiotherapy. Chest physiotherapy is a manual airway clearance technique that is used to clear lungs of secretions. This is when the person is lying in bed, and they will turn on their side, and we are going to pat their back like we're burping babies. and we're going to pat their backs, and we are going to start at the base of their back down by the bottom of their spine, and we are going to move those secretions up. Sometimes when physical therapy does it, it is called cupping. More serious MRSA infection will include skin and soft tissue infections, surgical site infections, bloodstream infections. Ladies and gentlemen, please listen up and then listen up one more time. MRSA, more serious infections, edema is present. So, complications of MRSA. MRSA is resistant to numerous antibiotics, therefore it can be difficult to treat. It can cause widespread infections. It is associated with increased morbidity and mortality rates. The highest mortality rates of 55% are observed with patients with MRSA-related septic shock. So, someone develops a MRSA infection. That infection will work its way into the bloodstream. They will become septic, and then when we think of sepsis, we will begin to think of septic shock. More complications. MRSA bacteremia. Patients have a significantly longer length of stay. Their hospital cost is higher because they're in the hospital longer. MRSA surgical site infections, 3.4 times higher risk of death. So when we are doing these dressing changes, we need to be extra diligent that we are practicing sterile technique or an especially clean technique. And again, because of this, hospital costs are going to be twice as much. MRSA infections can also lead to osteomyelitis and then toxic shock syndrome. Ultimately, infections can lead to multi-system organ failure and then death. Diagnosis. How are we going to begin to care for these patients? Diagnosis first begins with detecting the infection. So in order to contain outbreaks, hospitals have initiated surveillance programs. This is when someone comes from a nursing home, or if they come from assisted living, or if they have a wound, or if they have an active infection. We are going to culture them. We're going to culture the nares because that is the most common site. And we are going to send this culture off. We need to detect it early. Lower rates are found in healthcare settings where surveillance for antimicrobial resistant organisms occurred. So this means that the more we culture, the earlier we can detect it, the better we are in combating it. The risk assessment tool is used to identify baseline data on incidence, prevalence, and then transmission. So we are going to follow this patient and make sure that we are using the appropriate measures if they are positive for MRSA. Risk assessment will help to identify patient populations that are likely to be infected or colonized. The purpose of the risk assessment is to prevent transmission through the development of a plan that is based on facility data and conditions. So cultures are obtained from patient populations that are identified at risk through this risk assessment. Again, the most cultured site is the anterior nares. Other sites that are screened are areas of skin breakdown and then draining wounds. So, ladies and gentlemen, treatment. Listen up, and then listen up one more time. The best treatment will begin with prevention, and that means hand hygiene. Declining rates have been attributed to alcohol-based hand rubs and improved hand hygiene programs. This means that We're telling our staff, I can't believe that we have to tell our staff this, but we are telling our staff, please be sure to use the alcohol-based stations. Please make sure that you're washing your hands before and after care. Patients in healthcare settings who are either colonized or infected are placed on contact isolation precautions to reduce patient-to-patient spread of the organism within the hospital. Contact isolation precautions will include wearing gowns and gloves on entry to a patient's room, removing both the gown and gloves just prior to exiting, and then performing proper hand hygiene before exiting the room. Again, ladies and gentlemen, listen up, and then listen up one more time. Proper hand hygiene is essential. Listen up, listen up. Colonized or infected patients are placed in private rooms when available, or placed in a room with other patients who are colonized or infected with the same organism. Listen up, please, ladies and gentlemen. Contact isolation precautions are continued throughout the duration of the hospital stay. Please note, contact isolation precautions are continued throughout the duration of the hospital stay. Some institutions, some facilities will consider colonized patients to be colonized indefinitely. Some will consider them to be colonized forever. The CDC suggests that minor to moderate skin infections be treated with incision and drainage of abscesses without the use of antibiotics. We want to curb the use of antibiotics. And so instead of battling the infection with an antibiotic, doctor, if it's a wound, and if there is a pocket of fluid there, instead of waiting for the fluid to be absorbed by the body, doctor may consult a surgeon. The surgeon will take the patient to either a short procedure or to the operating room, open up the wound and do an incision and drainage, and then a lavage, clean out the wound, get to the base of the wound so that we can promote healing, healthy tissue, without the use of an antibiotic. No treatment recommendations to treat colonization, however. Some institutions may have a policy. So depending on the facility that you're working at or that you're doing clinical at, they may have their own individual way of handling colonized patients. Typical therapy to treat decolonized patients is the 2% Bactroban ointment that is administered nasally. So if somebody has been positive for MRSA in the past and now they are back in the facility, they may not have an active infection, so we know that they're colonized, but we are going to use the Bactroban anyway, just as a precaution. Ladies and gentlemen, listen up, and then listen up one more time. We are talking medications. The most used drug for the treatment is vancomycin. So what we are going to use to treat MRSA is vancomycin. That is the most used drug. It is administered either IV or it can be given orally. We are going to do a trough level, and this is blood drawn after a dose is given, but immediately before the next dose. So I'm getting ready to give my dose of vancomycin, but doctor wants a trough level. So before I hang this vancomycin, I'm going to call the lab, and they're going to come and draw the specimen, and then I'm going to hang the vancomycin. The trough level should be monitored weekly to avoid toxic doses and then maintain therapeutic levels. If the trough level is too high, then vancomycin can cause nephrotoxicity as well as ototoxicity. And I have cared for a patient in the past that did lose hearing in one of their ears because we didn't, or I guess the level wasn't monitored, they were on the higher end of the spectrum. So once the vancomycin dose was given, they became toxic and they lost the hearing in their ear. Also, weekly blood urea nitrogen, the BUN, and then serum creatinine tests are recommended to assess kidney function because of nephrotoxicity. So we have to keep an eye on these lab studies for the kidney function. Zyvox can be given orally or IV, and it's commonly used to treat skin and then soft tissue infections. Zyvox is a synthetic antibiotic that is bacteriostatic, which means that it will stop the organism reproduction against enterococci and then staphylococci. So Zyvox is given for 7 to 21 days depending on the infection. If Zyvox is given for more than 10 days, the patient then needs to be monitored for myelosuppression, including anemia, leukopenia, pancytopenia. Pancytopenia is the deficiency of red blood cells, white blood cells, and then platelets. And monitor also for thrombocytopenia, and that is a deficiency in their platelets. Serious reactions can occur when Zyvox is used together with psychiatric medications. Ibicubicin and IV Tigacil are used for the treatment of complicated skin and soft tissue infections. Cubicin exhibits bactericidal activity, meaning it will kill the organism against gram-positive organisms. So we will monitor this patient for muscle pain and weakness. Weekly CPK levels are drawn to assess for rhabdomyolysis. Rhabdomyolysis is the breakdown of muscle tissue, releasing proteins into the bloodstream. So patients with renal insufficiency need to have more frequent CPK monitoring. Again, we are monitoring the kidneys, and because we're looking at the kidneys, we are able to assess muscle tissue. Cleocin. Cleocin can be given IV or it can be given orally. It is one of the more common antibiotics to treat community-acquired MRSA. The most common side effect of Cleocin is diarrhea. So therefore, it can give us another problem, which is causing C-Diff. Bactrim. Bactrim can be given IV or it can be given orally. It is also used to treat community-acquired MRSA, skin and soft tissue infections. Dosing, again, must be adjusted for patients with impaired renal function, so we need to monitor that kidney function. The most common side effect of Bactrim are gastrointestinal, and so that would be nausea, vomiting, loss of appetite. Bactrim can cause sun sensitivity, so we need to educate patients to use sunscreen if they are taking Bactrim. We also need to educate patients to report signs of jaundice, that yellow scleria, that yellow tint to their skin, somnolence, and if the family notices that they are confused or if they themselves feel that they're confused. It is important to educate patients to stay hydrated, to prevent the formation of renal stones while they are taking this medication. So again, clients need to know, besides monitoring their kidney function, they need to know that one of the things that can happen is that they can develop a kidney stone. So they need to drink lots of water. Moving on to Vancomycin-Resistant Enterococci, that VRE. Enterococci are bacteria that will normally live in the GI tract, in the gastrointestinal tract, in the female genital tract. It is also found in the environment in soil, water, and food. Remember, MRSA is not commonly found in the environment. It is the third most common organism seen in nosocomial infections. So this tells me that this is an infection that I will contract while I am in the hospital. The organism can remain viable on environmental services for 7 days to 2 months. So it's going to live a very, very long time on that door handle, on that bedside table, on that bedside rail. Patients can remain colonized for prolonged periods of time, ranging from 7 weeks to 3 years. So again, this is an infection that is going to live a very, very long time. However, it is less virulent than MRSA. It may still cause many therapeutic problems because, again, of the resistance to antibiotics. VRE, these enterococci are considered low-grade pathogens. Anaerobic means that it is an organism that uses aerobic metabolism if oxygen is present, but it can switch to anaerobic if oxygen is absent, right? So if oxygen is available, heck yeah, that organism is going to use it. It's going to use up all that oxygen, but it doesn't matter because if oxygen is not present, it's going to live anyway. So it is anaerobic, and it can switch to anaerobic if oxygen is absent, and it is a gram-positive cocci. In the late 1980s, increasing prevalence of MRSA as well as antibiotic-associated diarrhea resulted in the increased use of vancomycin, and then now we have the emergence of VRE, because now we're using it and using it and using it, and then these microorganisms are saying, yep, we are mutating, and we are going to figure out how to battle you. So rates of VRE colonization and infection have risen steadily. Infections in the United States mostly occur in hospitals and are not associated with community acquisition. So again, it is a nosocomial infection. It is associated with higher morbidity and mortality rates, higher healthcare costs, and then prolonged length of hospital stay. Again, the patient is in the hospital longer. Prevalence is highest among patients who are critically ill in the ICU. High rates are also seen in hematology patients and organ transplant patients secondary to immunosuppression. Larger hospitals or teaching centers have significantly higher rates of VRE. Well, that just makes more sense because they have a higher census, a higher population, than a smaller hospital that will have fewer beds. So University of Pennsylvania is going to have a higher prevalence than Cape Regional Medical Center. Hand hygiene compliance also affects the prevalence of VRE, so again, it comes back down to hand hygiene. Hospitals with observed hand hygiene compliance rates at 59% or greater have significantly lower rates of VRE. Well, that only just makes sense, right? Because I'm washing my hands. Antibiotic stewardship is associated with lower rates of VRE. And again, this means when I am changing my central line dressings or my triple lumen dressings, my peripheral IV dressings, I am being more careful, I'm being more diligent, and I am using that antimicrobial disc. Efforts to reduce the use of vancomycin and cephalosporins have decreased prevalence in the United States. Ladies and gentlemen, please listen up. Please listen up and listen up one more time for me. VRE also has risk factors much like MRSA, and they will include a prolonged rehab unit stay. So, ladies and gentlemen, please pay attention. When I am referring to MRSA, I am referring to patients that are in the hospital, in a hospital setting. I know that there is hospital-acquired MRSA and community-acquired MRSA. So when I am thinking about MRSA for this discussion, I am talking about people that are in the hospital. The only way that I can differentiate, because VRE is also prevalent in the hospital, is when I'm speaking about VRE, I am going to section out this discussion, and we are going to talk about VRE living in a rehab setting. So again, ladies and gentlemen, when I am talking about MRSA, MRSA will live in the hospital setting. VRE will live in a rehab setting. I know that they exist in both facilities, but in order to make it easier for you to understand, I am separating it out this way. Again, MRSA will live in the hospital setting for my discussion. VRE will live in a rehab stay. Risk factors will also include a weakened immune system, a prolonged exposure to antibiotics, well, that only just makes sense, and then invasive procedures and devices. It is spread by direct patient-to-patient contact, indirectly on the hands of healthcare personnel, and again on unclean patient care equipment that is not cleaned. It's just wiped down very quickly because I need to use it again, so I'm not doing it correctly. Environmental services has not been called, and maybe insufficient drying time. So, large emphasis on prevention, as outbreaks are very difficult to control as antibiotic use increases, the microbial load of VRE, and then facilitates nosocomial transmission. So again, it is something that I am going to develop while I am, for my purposes, in the rehab facility. It is difficult to control as treatment options are limited, and polypharmacological approach may be necessary. So, clinical manifestations of VRE. Enterococci commonly causes urinary tract infections. We will see back pain. We will see pain on urination. They will have the sensation to urinate. They will have that frequency, that urgency. They may also have fever. Peritonitis. Peritonitis is an intra-abdominal and pelvic wound infection. We will see redness. The skin will be hot to touch. We may see purulent drainage. Bacteremias. Most likely we will see signs of sepsis, tachycardia, hypotension, fever. Complications of VRE. There is a growing list of resistance to antimicrobial agents. There is an emergence of Vancomycin-Resistant Staph aureus, meaning that if we have a staph infection, we can no longer use vancomycin to treat this infection because it is resistant. Prolonged hospital stays, prolonged antimicrobial therapy, higher mortality rates, bacteremia, again, tachycardia, hypotension, they may have a fever, increased cost of hospitalization, and then endocarditis. So diagnosis of VRE, again, begins with early detection. So surveillance programs to track colonization in high-risk populations are instituted. Hospitals may perform screening on any patient admitted to the intensive care environment, and then screening is done through the collection of perianal specimens. So with MRSA, we are swabbing the nares. We are swabbing the nose. For VRE, collection is done through swabbing of the perianal area. And again, the best treatment will begin with prevention, and again, that comes back to hand hygiene. So, some medications for VRE. VRE isolates are resistant to penicillin and ampicillins. So, ladies and gentlemen, please listen up, and then listen up one more time. Sinercid IV was the first antimicrobial agent available to treat VRE. It will inhibit protein synthesis. However, it is caustic to veins, so therefore a PICC line is recommended for long-term use. Dosages are adjusted in patients with liver insufficiency or cirrhosis, and the length of therapy will depend on the infection. So Synarcid, some of the more common side effects of Synarcid is joint pain, mild diarrhea, nausea and vomiting, and muscle pain. Zybox for VRE is the only oral treatment that is approved by the FDA. Cubicin is effective against more than 95.5% of the isolates, so it's very, very effective. And Tigacil can be used in vitro against VRE. Treatment of VRE colonization is not recommended, so we are not going to use that antibiotic ointment in the nares the way we would with MRSA. No antimicrobial agent available to eradicate VRE colonization, so there's nothing we can do. Moving on to Clostridium difficile, C. difficile. Ladies and gentlemen, listen up, and then listen up one more time for me. The most common cause of antibiotic-associated diarrhea in the United States is C. diff. It was first detected in 1978, secondary to increased use of antibiotics. So, in effect, are we giving our patients this diarrhea? Yes, we are. Yes, we are. 50% or more of hospitalized patients are colonized without showing any symptoms of this disease. Risk of colonization will increase steadily each day during a hospitalization. Ladies and gentlemen, listen up, and then listen up one more time for me. 96% of patients infected received antimicrobial therapy within the previous 3 months. So, I am going to know that if somebody has had diarrhea and if they have received an antibiotic in the previous 90 days, in the previous 3 months, there is a good chance that this diarrhea is considered C. diff. 85% within 28 days prior to the onset of symptoms. Mortality will be low. It will increase length of stay by 2.5 to 4.5 days. Infection increases in patients who have already had one infection, so we know if it's happened once, it is going to happen again. Ladies and gentlemen, please listen up, and listen up again. Toxins released from the bacteria in the bowel will cause this inflammation. Toxins released from bacteria in the bowel will cause this inflammation. Risk factors. Risk factors for C. diff are use of antimicrobials, the fact that they have received an antibiotic recently, past 90 days, past 28 days. And if they are older than 64 years of age, if they have been hospitalized, if they have received chemotherapy, if they have a nasogastric and NG tube, including feeding tubes, they are at risk. Gastrointestinal surgery, and then a severe underlying illness. Acid suppressing medications. Histamine blockers. Histamine blockers will suppress the normal bowel flora, creating an environment for C. diff to flourish. And then PPIs, proton pump inhibitors. So the pathophysiology of C. diff. How does this happen? Spores are resistant to many types of disinfectants. heat and dryness, so they live a very long time. They can live for months on surfaces, in skin folds, and on the hands of healthcare workers. So again, not only do I need to practice really, really good hand hygiene, I should probably also be wearing gloves. It is transmitted through the oral fecal route, and it is almost exclusively found in the healthcare setting. So the ways in which patients are exposed in the hospital will include, ladies and gentlemen, listen up, and then listen up one more time. Contact with healthcare workers with contaminated hands, contact with contaminated environment, direct contact with a patient with an infection. And ladies and gentlemen, please pay attention. Again, the recent use of antibiotics. Hands of healthcare workers are the primary source of the outbreak. Patients must be on contact isolation precautions. And ladies and gentlemen, listen up, and then listen up one more time for me. A stool sample is required for diagnosis of C. diff. The sample needs to be sent to the lab immediately. As soon as we obtain this specimen, it needs to be transported to the lab, and culture and sensitivity is required. So we need to do a stool sample for C. diff, and we need to do a stool CNS, a stool culture and sensitivity. So clinical manifestations of C. diff. What is the patient going to say? What are we going to see? Well, they can be symptomless. They may have mild diarrhea. So there is going to be a need for increased fluid intake, or they may have moderate diarrhea. And so again, they may have a need for increased fluid intake. Fatal pseudomembranous colitis is a severe inflammation of the colon, and it is fatal. This means that the colon, the whole entire colon, and we know how long the colon is so inflamed, and it becomes so toxic and so infected that there is no recovery. Ladies and gentlemen, listen up, and then listen up one more time for me. We are talking about complications of C. diff. So we are talking about volume depletion, otherwise known as hypovolemia. We remember this term, right, from semester number 1. It means that we are dehydrated. So there will be an increase in the serum creatinine due to this dehydration. And remember, we remember this from before, looking at that serum creatinine level. If the serum creatinine is elevated, and we hydrate the patient, and if that serum creatinine comes to a normal level, then we know that they were just dehydrated. Renal insufficiency. Another complication, ladies and gentlemen, listen up, is electrolyte imbalance. Electrolyte imbalance is hypoalbuminemia, a low serum albumin level, hypotension, which we know is low blood pressure, peritonitis, inflammation of the peritoneum, and then a paralytic ileus. A paralytic ileus is an intestinal obstruction. More complications of C. diff. Toxic megacolon. Toxic megacolon is the rapid dilation of the large intestines. It is a medical emergency, ladies and gentlemen. Pseudomembranous colitis, again, often fatal. Sepsis, death. Subtotal colectomy. Subtotal colectomy is when part of the colon is removed because it is diseased. It is so inflamed that it will not recover. And then a total colectomy, is the removal of the entire colon. Skin breakdown is also a complication of C. diff. Okay, ladies and gentlemen, so medications for C. diff. Before treatment can begin, the suspected causative antibiotic must be stopped. So if the patient is on multiple antibiotics, that means we need to stop all antibiotic therapy because we don't know which one is going to be causing the diarrhea. So we need to stop everything and then we move on. So flagell, ladies and gentlemen, listen up, and then listen up one more time. Flagell is the treatment of choice in almost all patients with C. diff. Flagell is the treatment of choice. The first line agent in the treatment of mild infections. It is inexpensive and it will decrease the risk of VRE bacteria. However, it may cause abdominal discomfort, little cramping. It may cause loss of appetite. They may develop a metallic taste in their mouth. Flagell may also turn the urine a reddish brown color. So when you are giving your patient education, you need to let them know this so that they don't think that they're bleeding, they don't think that there's something else going on. They need to know that it's a side effect of the medication Flagell. They may not drink while they are receiving treatment. They also need to be monitored for H. pylori, that is a gastrointestinal infection, during their therapy. And Flagell should not be used beyond the first recurrence. So if there is another recurrence of this C. diff, then Flagell will not be the treatment of choice. Vancomycin. Vancomycin is the first line treatment of the initial episode of the severe diarrhea. It will cause prompt resolution. There is significant lower risk of treatment failure, and it will kill the bacteria at the site of the infection in the colon. Okay? Difficile. Difficile will inhibit RNA synthesis. Some of the more common side effects include vomiting and then other GI disorders. And it is used for patients with recurrent infections and if you are resistant to vancomycin. Probiotics. Sometimes we do administer probiotics for diarrhea. Probiotics are live bacteria and yeast. They effectively reduce the incidence of simple antibiotic-associated diarrhea. Their efficacy, however, is inconsistent. FMT, fecal microbiota transplantation, FMT, is an emerging treatment option for those with C. diff. The success rate, as noted, is 97%. It will create an environment that is resistant to C. diff. It is indicated for patients who have had 3 or more occurrences with unsuccessful treatment of 6 to 8 weeks of vancomycin. And relatives are the most effective donors. So, Acinetobacter baumannii. It emerged as an important healthcare-associated pathogen. It is identified as a multi-drug resistant organism because it is resistant to more than 3 classes of antibiotics. So yes, it is multi-drug resistant. The emergence is due to the use of broad-spectrum antimicrobials and transmission of strains among patients. Incidence in hospital-acquired cases is continually increasing. So patients are colonized in 1 or more sites, may also develop a clinical infection. Prevalence and resistance is increasing in the community. Risk factors. Risk factors for Acinetobacter. Ladies and gentlemen, listen up, and then listen up one more time. A recent surgery, a central venous catheter, A tracheostomy. A tracheostomy is used to maintain a patient's respiratory status. Mechanical ventilation is also used to maintain their respiratory status. Enteral feedings, exposure to antimicrobial agents, and then prolonged hospitalization. An ICU admission, and then nursing home residence. Ladies and gentlemen, listen up, and then listen up one more time. Vascular catheters and the respiratory tract have been identified as the most frequent site. Vascular catheters and the respiratory tract have been identified as the most frequent site. So the pathophysiology of Acinetobacter, it naturally inhabits water, soil, animals, and humans. It grows at varying temperatures and pH environments. There are more than 25 species. It has been recovered from the skin, throat, and the rectum of humans. Ladies and gentlemen, please listen up, and then listen up one more time. Acinetobacter colonizes in the respiratory tract. The ability of Acinetobacter to survive for weeks to months on both dry and moist surfaces, so it doesn't matter what the surface is, it can survive. Higher rate of infection in the summer months. It is more humid. The more humid air of the summer months favors their growth. It is spread by direct and indirect contact, and it can be spread patient to patient if they are sharing the same room. Ladies and gentlemen, listen up one more time. Indirect transmission is contaminated person or object. Remember, an indirect transmission means that there is a contaminated person or object. So, therefore, the unclean hands of a healthcare worker, contaminated skin, body fluids, equipment, or the environment. And now, because it lives in the respiratory tract, respiratory care equipment, wound care procedures, humidifiers, patient care items are all sources of contamination. So clinical manifestations of Acinetobacter, the typical sites of colonization are in the respiratory tract. Ladies and gentlemen, please note, listen up. The typical site of colonization of Acinetobacter is the respiratory tract. Also, blood, pleural fluid, and the peritoneum. The urinary tract, surgical wounds, the central venous system, the skin, the eyes. Ladies and gentlemen, please listen up, and then listen up one more time. The most frequent infections are ventilator-assisted pneumonias and bloodstream infections. Please note. So some complications of Acinetobacter are increased mortality, increased morbidity, increased length of stay, ladies and gentlemen. It is increased by 18 days. Increased length of ventilator days. It is increased by 5 days. Medications for Acinetobacter. Ladies and gentlemen, listen up, and then listen up one more time. Unicin can be given IV or IM. It is used for mild to severe cases. There are better outcomes associated with lower severity of illness. It will commonly cause that diarrhea or a rash. And, ladies and gentlemen, please note it will decrease the effectiveness of contraceptives. So female patients should be encouraged to use a backup form of a contraceptive. The carbapenems. Other carbapenems are Primaxim, Merum, Doribax. Most important therapeutic options for these serious infections. Excellent bacterial activity. However, resistance is creating challenges. So remember that these organisms, they mutate. Every time we get a handle on them, they mutate. So we are constantly working to create a resistance. Carbapenems are the treatment of choice. Dosages need to be adjusted for patients with renal impairment. It can commonly cause nausea, headaches, and then there is something called Stevens-Johnson syndrome. Although rare, this is an epidermal necrosis that causes the epidermis of the skin to separate from the dermis, and this is caused by severe medication sensitivity. Again, that is Stevens-Johnson syndrome. Aminoglycosides. Some aminoglycosides are Tobradex. Tobradex can be given IV. Tobramycin peak levels, drug level is obtained 30 minutes after administration. Remember, we talked about the trough level being administered before administration. Well, this is a peak level. A peak level is obtained 30 minutes after administration, and the trough levels are obtained every 3 to 4 days to maintain a therapeutic dose, a therapeutic area. Amikin. Amikin is given IV. However, again, it may cause nephrotoxicity and ototoxicity. So peak and trough levels are obtained to maintain a therapeutic dose. Olistin. Olistin may cure or it may have great improvement with severely ill patients. It can be given orally, IV. It can be given IM. We can instill it into the bladder or it can be inhaled. It is poorly absorbed in the GI tract, so the side effects are minimal if it is taken PO. But as you can see, PO, because it's absorbed poorly in the GI tract, would not be the first treatment of choice. And the renal dosages must be required because renal adjustment is required because we need to be looking at that kidney function. Sorry, I misspoke. Tetracyclines, minicins, Dorex. They can be given IV and PO. The dosage and the length will depend on the type and the severity of the infection. They will also decrease the effectiveness of contraception, so females should be encouraged to use a backup method of a contraceptive. Also with tetracycline, some patient education. It can cause sun sensitivity, so they need to educate on sunscreen, using a sunscreen. The medication should be taken 1 hour prior to a meal or 2 hours after a meal to assist with absorption, so essentially it needs to be taken on an empty stomach. Adequate fluid hydration to prevent esophageal irritation or ulcer. And we need to monitor liver and kidney function with tetracyclines. So, nursing management, what are we going to do? We are going to assess and then reassess. We are going to assess for signs and symptoms of infection, fever, tachycardia, tachypnea, hypovolemia, that low blood plasma level. We are going to monitor their diarrhea. We are going to monitor for C-Diff. We are going to look at those wounds. Are they red? Are they warm? Are they positive for purulent drainage? Some nursing diagnoses for this population. Risk for fluid volume deficit related to C-Diff. Ineffective airway clearance related to pneumonia. Alteration in comfort related to the diarrhea, the abdominal pain, etc., whatever clinical manifestations are present. Risk for skin breakdown related to diarrhea. Impaired skin integrity related to the wound, to the diarrhea. Impaired urinary elimination related to a UTI. This is a secondary infection. Nursing interventions, what are we going to do? We are going to assess and then we're going to reassess, and if need be, we are going to assess again. We are looking at vital signs. They may have a fever, tachycardia, tachypnea. They may complain of pain. There may be a wound or a surgical site, so we need to assess for, is it red? Is it swollen? Is it painful? Is it hot to the touch? Does it have drainage? We are going to monitor the oxygen saturation level. It may be decreased because they have pneumonia. We are going to assess their skin turgor and their mucous membranes and monitor for dehydration. We are going to monitor their urine output. Are they dehydrated? Do they have a secondary UTI infection? We're going to look at lab studies. We're going to look at the white blood cell count. If the WBCs increase, they may have a C-Diff infection. We're looking at the serum creatinine level. We are going to monitor for dehydration and impaired renal function. The electrolytes and the albumin levels, again, we are looking for dehydration. We're going to monitor the bowel movement frequency and the consistency. There may be an increase in frequency that may cause dehydration. And again, if they have diarrhea, we are going to monitor that skin integrity for breakdown. Some nursing actions. We are going to place this patient on contact isolation precautions, and this is to prevent transmission to other patients. We need to talk to them about hand hygiene, and the nursing staff and ourselves, we need to be very diligent with our hand hygiene to prevent transmission. We are going to administer antibiotics if needed to treat the infection. Administering fever reducers to reduce the fever and increase their comfort. We are going to administer IV fluids and encourage PO intake to treat or prevent this dehydration. And if necessary, administer supplemental oxygen because they may have that pneumonia, so we are going to treat the pneumonia. Early mobility, we are going to get these patients up and sitting in a chair or walking in a hallway to decrease their risk of atelectasis. Pain medications if they have a wound or a surgical site. And if they have a C. diff infection, we are going to stop the causative agent, that causative antibiotic, to help reduce the diarrhea. We are going to perform wound care as ordered. We are going to monitor for infection and then assess for the healing process. We are going to perform good pericare to prevent and monitor for skin breakdown. We are going to encourage family visits and other diversional activities, and this is to prevent depression because remember, this patient is going to be on isolation. We are going to teach the family and the visitors to maintain these contact isolation precautions, and we are going to teach them about good hand washing. We are going to educate the patient to take antibiotics as ordered. So if they go home on a PO antibiotic, they need to finish the course. They need to finish the course to prevent reinfection. And we are going to educate them on signs and symptoms of infection. The patient and the family must be able to recognize signs and symptoms of infection. So, the study focus for this area of education, for this content, are the roots of transmission, the clinical manifestations of C. diff and MRSA, risk factors for Acinetobacter, C. diff, and VRE, the priority nursing care for a patient with an infectious disease, medications for MRSA and VRE. How do we diagnose C. diff? The pathophysiology of C. diff, and then the complications of C. diff. Ladies and gentlemen, thank you very much for your time and for your attention. Please reach out with any questions or concerns. Thank you again.